MDS is an interesting space now because we have several agents approved in this setting. So in the frontline setting, we have EPO, or erythropoiesis-stimulating agents, and we have luspatercept, both on a head-to-head trial through the COMMANDS study showed that luspatercept actually might have a longer duration of response and is having a trend towards survival benefit against ESA. So generally this is like a moving field where ESAs are slowly getting sort of replaced by luspatercept for several reasons, including potential disease modification, better response in both RS positive and RS negative subsets, and longer duration of response for sure in the RS negative subset. So those are the sort of the frontline options. And then we have imetelstat that is approved in the second line setting after failure of one of these agents in the front line. There are some neutropenia. There's some neutropenia that is seen, potentially some thrombocytopenia, but again, manageable, but it's a good, no patients are not being harmed. So we have a good sort of second line agent here that to be used. And in lower risk MDS, you kind of want to run like a marathon. So you have your first line agents. I personally have always used luspatercept as frontline, especially after the COMMAND study. And ESAs still have some place in the frontline setting, for example, in patients who have CKD, where they may actually need the EPO to stimulate sort of the EPO deficiency, and then maybe luspatercept. But generally, I think luspatercept is being used frontline. And one of the interesting aspects of EHA, there were a couple abstracts presented on Maxillus, for example, where now we are reversing the dose game, where instead of the slow step up, we're starting right from the beginning at the high dose. And that's very interesting, especially for patients, because if it's safely done and it looks like it was safe, there were no adverse side effects different than what was expected in the step-up approach, then there's potentially saving a lot of time in trying to get through that right dose, because most people are, in the end, escalating up to 1.75. So I think as these trials read out more and more, I think physicians and patients are going to feel comfortable at just starting at the higher dose, and you'll get a quick response, and then you move on if you don't respond. So I think it's a very important trial.